I will try to show you a quick overview about the evidence for dual mobility, and then I'll show you some cases out of our clinical practice. We have now the system here in our use in the last 2 years, and I hope I can give you some ideas how we use it and what are the advantages in the daily use of this system. So when we look at the hip arthroplasty, it's one of the most successful surgical procedures, as you know, and we have about more than 100,000 procedures a year only in Germany. We talked about the large numbers we still do implant in Germany. We have elective and fracture care cases. We have more fracture care, of course, in our hospital. And besides infection and prosthetic fractures, dislocation and accepted loosening is the most dreadful complication, and the main reason for revision surgery is the dislocation of the hip arthroplasty. And the incidence of dislocation is 1 to 2% of all hip dislocations, up to 28. I wouldn't go in a hospital with 28%, but this is what the literature says, and most of the dislocations occur in the first 3 months. So we have main reasons. We have one of the post-traumatic, the low energy fall, the wrong step, as you all know, that the patient tell, and an opportunity caused dislocation of the hip arthroplasty. There are some reasons and some classifications for the hip dislocations. We know that the cranial dislocation is mostly caused by an adduction with a damaged inlay, with a high angulated cup, or insufficiency of the adductor muscles, caused by a very invasive approach to the hip. We know that the dorsal dislocation is caused by a flexion and adduction with a low anteversion cup and maybe an impingement, as you can see it here on the picture, or an anterior dislocation, induction and external rotation with high anteversion shaft or cup position, or as well an impingement. And we have some more risks for dislocations. When you go into the literature, we have, of course, the muscular imbalance. We have to be sure that we implant the prosthesis in the right position. Therefore, we do a planning before. We have to be aware of the offset and all this, you know. But there are some more things we can't change or we can't influence, as a dementia, spinal fusions, morbus Parkinson, prior head necrosis of the femur head, anatomic malformations, fractures, and revisions in the past. So these are the risk factors for dislocation that you have to know before you go into the surgery. And maybe one of these reasons may lead you to the primary decision for a tripolar cup as well. The approach is a big topic always. We know that the dorsal approach has the highest rate for dislocations in the first 3 weeks. We know that the position of the acetabular and the femoral components and the tension of the soft tissue, and of course the experience of the surgeons and a good planning is one of the most important things for the later success for the procedure. So sometimes it's just not working, and sometimes you see these cases where you have no muscle anymore for the pelvic trochanteric stability. You have a lot of cement in the hip, and you have revision stem, and you have a poor bone quality, and you have a very ill patient. And unfortunately, we often have these patients that get referred from other hospitals because not the surgeon say this is the problem, but the anesthesia says we do not do any anesthesia for them anymore, so we got referred these patients to our clinic. And then you have to find a solution. So this is the way to the picture I showed you. She had a periprosthetic fracture of a loosened prosthesis here on the left side of the hip. And there was done a revision in the OR, and the whole proximal femur was gone. And the problem is then and this is the same in the trauma cases, that you have no stability here in the upper part of the femur to the hip and to the rest of the pelvis. And then the second problem here in this case is, I think that the cup is not implanted in the right position. So in this case, now what are you doing? This patient is very old. She's very had suffered from the procedures she went through. So you need an easy and straightforward solution, and therefore we just changed the PE cemented inlay into a MaxiMotion cup, a cemented MaxiMotion cup. Because of all the comorbidity, we did not get rid of the whole cement here because of the risk of bleeding and the whole the duration of the operation time. We just removed this and cemented the cemented cup of the MaxiMotion in, and there was no further dislocation, and the patient was able to walk around a little bit, not functionally very good, but get rid of the dislocation. So this is maybe one of the things that I really like from the MaxiMotion system, that you can just change very complex cases in just one step into a very secure and reliable situation. You all know how this thing works, so I go through this, that we have the different options. The speaker before talked about the offset adapter with an angulation to change maybe the angulation of the prosthesis. We sometimes use them. Not very often, but I show you later on a case where I think that's suitable. You can check the rotation of the different angulation when you attach to the prosthesis. You don't have to remove them, and it's a very small case, a very straightforward system that everybody knows how to handle it with just a few procedures to learn it. So what are the evidence of dual mobility? Are we allowed to do all this? I searched into the literature for some actual obligations. So in this study, in the Bone and Joint Journal, they had a study with 3,008 revisions with the dual mobility, and there was always the fear of an interprosthetic dislocation of the dual mobility systems, and they only occurred about 1.3 and 1.3%, and the extra-articular dislocations, these are the dislocations from the whole head, from the cup, was occurred in 2.2%. So the fear of an interprosthetic dislocation, that the two components get rid of each other, is very low. This is the first one. And they showed in this study that the dual mobility articulations have very low rates of instability and a good survivorship in primary total hip replacement and revision, and for the femoral neck fractures. And another literature I found from 2019 was examining the costs that may occur after using these dual mobility systems, and they compared it with large femoral heads to dual mobility, and they showed that in the 3 years follow-up, the dual mobility constructs have lower risk of re-intervention and lower healthcare payer costs compared to large femoral head revisions. So this is quite an optimistic thing we found in the literature. And as I told you, we have a lot of trauma cases, and you already saw in the last lecture a trauma case from a proximal femur fracture, and we often have this problem that if you do not do a suitable reduction of the proximal femur and you just place a long nail in, these fractures will not heal and they will collapse always. You only have one shot in these procedures, so if you do a procedure like this, you can plan for the prosthesis in the next 2 or 3 weeks. And this this occurred, of course, just a few weeks later. So we had this situation. And as we know, I showed you at the beginning that the post-traumatic cases have a very high risk of primary dislocations. We used the dual mobility system. In this case, she was very old too. We had a cemented stem. You see the problem of the proximal femur again. The surgeon who did this was afraid of a split of the femur, so we just put some cerclages to be aware of a femoral split, because the fracture was going down here to the trochanter minor, and he tried to to be aware of putting away all the bone material and the attachment of the muscles here in the proximal part of the femur. But in this trauma cases, it is really useful to use the MaxiMotion device just to be sure that there will be no dislocations in the future. And as I told you, usually you don't have more than 1 or 2 attempts to have a good solution for these very old and very sick patients. You should use a solution that is very secure. So I think this is one option, especially for the geriatric patients, to have a final solution with no dislocation anymore. This one was referred from another hospital to our unit with a dislocation, with repeated dislocation, with an ASCA prosthesis. Everybody who knows these ASCA prostheses and everybody who always try to get them out of the bone knows that if you try this, mostly all of the femur is gone afterwards because they are very sticky into the bone. And in this case, he wanted a revision. There was no infection. We did an examination of the soft tissues in advance, and there was no infection. So he was a patient who suffered from a severe COPD, and we tried to concern him to try it again, but he had about 5 or 6 dislocations, and he was fed up of all the things, and so we changed into a cup revision with the MaxiMotion system, and in this case we used the BioBall adapter too, as you can see, just to be sure here to have a little bit more stability and a little bit more offset than usually used in normal hip revisions. But he was fine afterwards. He had primarily a full-bearing leg on the left side, walked around, didn't come to our hospital again. These are usually the cases we see every day, so post-traumatic problems after an acetabular fracture in this case. with 2 documented dislocations. So you see 2 problems. You see these, of course, the dislocation, but you can also see a loosening of the cup, and you have a fracture close to the acetabula. So it's not a very nice procedure usually, just to get rid of this revision cup already he had in. And we talked to this patient and looked what can we do. So we changed the cup with an augment revision system here and combined it with an cemented MaxiMotion cup. And the nice procedure here is that we could leave the stem into the femur and hadn't open it up and do a revision on this side, because the rotation and the angulation of this femur was okay. So we couldn't just change the cup, and he was fine afterwards. This is a case from my unit from septic surgery. He had a severe hip and pelvic fracture, and had an infection there up to the psoas muscles, and we did several revisions, but we couldn't get rid of all the material because it was an early onset infection in this case, and the whole thing would have been collapsed. So we did a resection of the femoral head and did a spacer in, and treated him with the adequate antibiotic therapy. And then we did a CT scan, and we from another company we got a customized cup we used, and we planned the screws to get beneath the plates that they are in. And we combined this cup here that fitted very accurately in this defect here in the hip with the duomobility system, just to be sure that there will be no dislocation. And he was very fine afterwards. He had primarily a weight bearing from half of the weight he has for 6 weeks, and afterwards he had full weight bearing, and there was no infection anymore. And he just visited us 2 or 3 months ago in our outpatient unit, and is quite well. So let me summarize all this. We have a reliable system to prevent and treat hip arthroplasty dislocations, and in combination with the tripolar cup, even more security. We have an uncemented and cemented option. We have a combination with almost all stems and cones. This is one of the most one of the most advantages, I think, in this system. But sometimes you got hip dislocations from patients that have a cemented stem that is there in for 15 years, and he was happy with the hip all the time, and the problem is only the dislocation or a secondary loosening of the cup. And you can just change the cup without changing the femur component. And the very old systems have sometimes adapters of the head that are not in your hospital anymore, a different size of them. So you can have a rescue system for these cases, just to combine with the usual cones and balls. We have the possibility to change the offset and the length without changing the implant. The metal and the ceramic head is available for special revisions, and it depends on what they had before, and it's easy to use, and you have very small trays. Thank you.